Thank you so much, sir. It was very enlightening. Just an announcement, all doctors are requested to register their name outside near that counter, CME counter, because for the CME credits, and today is the last day, so please, all of you, just a request. Now I would like to call upon our esteemed speaker, Dr. Lali Shah, the President of Urological Society of India. Dr. Shah is a renowned expert in urology and has made substantial contribution to the field of minimal invasive surgery, particularly in the management of complications during laparoscopic procedure. Dr. Shah is going to talk about ureteric injury during laparoscopic gynecological surgery and how to avoid and manage it. So please join me in welcoming, sir.
Thank you. Good afternoon, respected chairpersons, dignitaries of the dais, and friends. After a great morning session, sumptuous lunch, some of us are used to have a siesta time. If I go to sleep, please forgive me. Topic today to discuss is ureteric injury during laparoscopic gynae surgery, how to avoid and manage. These are the various risk factors: enlarged uterus, obesity, previous pelvic surgery, previous history of radiation, endometriosis, PID, distorted anatomy. At most of the time, it is a massive bleeding where the clamping goes on irrelevantly and it happens. Improper light and assistance also is a surgeon's experience. These are all the common things. This is about the course of the ureter, which lies in the vicinity of these various organs, like uterine artery branches, and it will be just curling around under that, uterine vessels. So these are the areas where the possibility of injuries are there. And these are the various points during various surgeries the injury of the ureter can occur. The incidence reported in various series is 0.3% to 2%. Of course, over the years, now that percentage has reduced to a great extent. It is commonly said and assumed that laparoscopic surgeries have more incidence of ureteric injury than open or vaginal. And of course, it all depends on the surgeon's experience. So how to prevent that and how to manage that? So in preventive aspect, for the preoperative time, especially in the high-risk cases, we must have a preoperative imaging, including the CT, IVP, or plain IVP, or whatever is there. Another thing which has been recommended is putting up the stenting. Though it is not very commonly practiced, but at least in the high-risk cases, it should be practiced. One of the illuminated DGS is there so as to make it easier. Because in laparoscopy, the ability to palpate the stent is not as good as it may be in the open surgeries. So this is how we can put on a stent and you make the ureter palpable. And these are the illuminated stents. And these are the places where we need to take care at pelvic brim during clamping of infundibulopelvic ligament, at bifurcation of common iliac artery, lateral pelvic wall inward dimes, at broad ligament, ureteric canal inward dimes, upper vagina during clamping of vaginal angle. The causes of injury usually will be crushing, ligation, transection, angulation, ischemia with cautery, or stripping at verdyme. These were at the intraoperative one. In postoperative, it can be avascular necrosis of ureter, or kinking up, or the sloughing out after the infection of hematoma. Intraoperative diagnosis can be done by IV methylene blue, can be seen there, a cystoscopy, and to put up an RGP, that is a retrograde pyelography, would be able to help it out. This is the various grades: hematoma, lacerations, where 50% transaction or more than 50% transaction, or a complete transaction, or there is an avulsion of ureter. It is commonly said that the best time to treat is the intraoperative one, but in most of the cases, it may not necessarily be the intraoperative period when we would be able to diagnose. More than half the cases are diagnosed in the postoperative period. And then in that situation, the common thing is when to do the surgery. So unless until there is a suggestion of an on-site infection there, it should be done as soon as possible, because this will reduce the misery of not only the patient, but also reduce the misery of the gynecologist. So the whole idea of thinking about that 6 weeks or 12 weeks waiting period so that the edema would reduce is of no use. It has to be done as soon as possible, because in the ureteric injury, you are not going to go to that particular place. You are going to divide the ureter and do a ureteral neocystostomy. So both the tissues are healthy. In unhealthy area, you are not going at all. So there is no justification of waiting. In preoperative measure, the surgeon should know where the ureter is all the time. Proper approach and exposure should be there. It should avoid blind clamping and mobilize the bladder away from the operative site. And the limited use of corti should be there. And at all times, you should try to identify the ureter. And in cases where there is adhesions and all that, it is better to identify at pelvic brim and do the ureterolysis. In post-operative period, if there is a problem, then these are the various investigations to rule ultrasound, CT, IVP, and RGP. Now the treatment is, it can be a conservative treatment. The conservative treatment is a DJ stenting, which may be possible in some of the cases, especially if the transaction of the ureter or the ureteric injury is not under the complete circumferences. But it has a disadvantage also. Say, for example, there is an injury and the urologist has, maybe with the cystoscope or maybe with the ureteroscope, is able to pass a stent and the patient becomes dry. But if the injury was more in, sorry for the stutter, if the injury was in more than 50% of the circumference, then it is bound to form the stricture, and the patient in general are not, this has been our experience, that in general they are not willing for second part of the surgeries. And invariably they would get lost, and later on they may come with a totally burnt out kidney. So that we need to be careful about that. Second thing is about the surgical treatment. Surgical treatment can be ureteric reimplant. Like I said, both the parts are healthy, bladder as well as the ureter. So a new opening is formed. And if the gap is more, then probably we will have to do the ureteric reimplant with the sauce hitch. And if the gap is still larger, then we will have to raise a Boari flap, a flap of the bladder, and a higher anastomosis is to be done. Now, we need to think about this, because there is no dearth of cases, there is no shortage of cases for this particular reason in India, and especially in the changing medico-legal scenario as on today. So what we need to do is that our counseling, pre-operative counseling, should be very, very good. Another thing is that in case of litigation, the only thing which is going to save us is the medical records. And in general, what we have been finding is that medical records are taken and very lightly. Forget about the institutes or the medical colleges or the corporate hospitals where there are residents and all that, but 70 to 80% of the medical care is provided by the small and medium nursing homes, where the doctor itself is the lowermost person also and the highermost person also. So there the medical record keeping takes a back seat, and that is where the problem occurs. And one of the most important part of the medical record is the informed consent. If you would see any surgical specialties, if you will do the auditing of the cases, that you would find that in the court where the litigation has gone against the doctor, more than 50% of the cases are because of the invalid informed consent. So our informed consent should be very, very good. Another thing that I said was, in our operative notes, we keep very, very poor operative notes is written. What we write is laparoscopic hysterectomy done, or lap-assisted hysterectomy has been done. That's it. We do not write anything more than that. So when the matter doesn't go to litigation, it doesn't matter what happens, what you have written, the record is there, not there, it doesn't matter. But if it goes to the litigation, and that time, if there are no details are taken, then court assumes that those details were not taken care of. Because any complication is not necessarily a negligence. But the complication has occurred, then, and if the matter goes to the litigation, it is our duty to prove, and of course by documents, that these are, number one, a common complication, known complication, and we have taken preventive steps to avoid this complication, we were vigilant enough to be able to diagnose it early in time and take the proper management. Because law does not expect you to be the best in the world, best in the country, or best in the city. Law wants you to be on an average one of your class. But law expects you to do your best. And law also understands very clearly that your best may not be good enough at many times, and it accepts without any problem. But if your record keeping is not there, you would not be able to tell that you have done your best. And that is what is very, very important. Another thing is call for review. Like I said about this DJ stent and the lower stricture which we form, the patient goes on of that. There are cases which have been recorded and the doctors have been found negligent. Where? Because they have not called the patient for review. And it is always, even financially also it is viable. You always call the patient for review. If he comes, he is going to pay you money. He or she is coming, they are going to pay you money. What is wrong in that? So last line, I mean, all discharge tickets should be there that please come for review after XYZ number of days, whatever we want to write. And this is the consent that I have been asking. Of course, it can be in a different thing, whatever is there. But one line, because patient signs and later on they say, no, nothing was told to us. They said that everything will be all right in one day. So it is better that the patient writes in their own handwriting, in their own language, कि हमें बीमारी और बेहोशी और ऑपरेशन के बारे में विस्तार से बताया गया है. If the patient is writing that and signing that, it helps tremendously. 4 years ago, in one of the cases against myself, only this particular line had saved me.
Sir, 30 seconds.
Another thing that I have been recommending is at the time of discharge, take the consent from the patient. Discharge consent is not a very proper terminology, but I could not get any better term. So that is what he said, that he hereby certified that discharge summary, investigations have been given to us, nature of problem, prognosis, plan of management, treatment given in the hospital, possible complications and failures, need for regular follow-up, precautions and possible follow-up procedures, etc. have been explained to us to our satisfaction. If the patient is signing these two consents in a proper way, most of the time you would be very, very safe. Thank you very much for the patient listening, and wish you all a very safe non-ureteric injuries practice. Thank you very much.
Thank you, Dr. Shah. I think it's very important for all of us, and especially gynecologists, to understand the importance of ureter, the anatomy, their position. Obviously, they face it every day, in and out. And I would say that they should not be scared of ureter, but they should be friendly with ureter. They should know how to handle it. And I think all gynecologists must know how to do a cystoscopy, especially a check cystoscopy. What's your view on that, Dr. Shah?
Yes, I think so.
Thank you very much.
Yeah, it was an excellent presentation. So it's not a problem for gynecologists, it's a problem for colorectal surgeon also. We're banging the ureter. And it happened in my first case from my fellowship that an only thing that saved me was a proper counseling to the patient. In fact, I sat with the patient and explained to the patient that there's always a chances that it may have ureter injury and patient may have a colostomy bag. So the patient was very focused upon the colostomy bag much. So it happened and we immediately recognized it. I called the urologist and we fixed it. So we came out and I was like nervous and the urologist was also with me. So we came in and I said, look, good news that patient did not have colostomy, but bad news is that we had a ureteral injury. He said, don't worry about ureteral injury. I was more concerned about the colostomy. So the discussion is very, very important. And I will give you an example of the America system is that we live in the lawsuit everywhere. And everybody wants to sue because they think the doctors or the surgeons, they make a lot of money. An easy way to get rich by putting a lawsuit. So we have a settlement. Settlements means when the case happens, the lawyer takes the case immediately. Anything goes to the lawyer is going to take the case because they want to settle the case. The case does not go to the trial. If it goes to the trial, you're exposed to millions of dollars. And, because the jury is sitting there like 10, 15 people who are illiterate. They do have no clue and they've been forced out from work to sit in the court. So they can say any numbers, like you may sue for $10 million or $15 million. So the problem is happening is that they go for settlement. So only thing you can save yourself from settlement is by good rapport with the patients. That's the most important. Even if you write a nice consent, explain everything, that is not going to protect you from the lawsuit if it goes to the court. So building a good relationship with the patient, explaining in details, that is going to save you a lot. And I've seen that a lot of my friends who practice in India, there's also seeing a lot of lawsuits there. So it's going to be US pretty soon. Like, you have to live with this condition. So unfortunately, thank you.